So we're quite lucky to have Dr. Bahaa here in Cochin with us, someone who's done a lot of work with synthetic ligaments and a lot of orthopedic devices over the last 40 years. And I've heard a lot about your team over the last couple of weeks that we've spent together. So welcome to India. Sitting here with Dr. Jacob Varughese, who happens to be my father as well, and myself, Dr. George. And I think it's quite a good opportunity for us to sit together now and do some mutual learning about what you've learned over the last 40 years and the evolution of using synthetics to help patients get better back from injuries, whether they're sports injuries or muscle tendon injuries. So if you could just tell us a little bit about where you're from and where you work and your academic background, that would be great.
Thanks. First of all, I'd like to say how honored and delighted I am to be invited to your prestigious place here. And I'm delighted to answer your questions. I come originally from Egypt, and I did a first degree in mechanical engineering in Asyut University. I did my PhD at Leeds University, and both were in engineering. And after that, I was really hungering for working in the medical field and putting my knowledge, engineering knowledge, in the medical field. So bioengineering was the most sensible approach. I joined the rheumatism research unit within the medical school at Leeds University, where the boss was a very entrepreneurial in his approach. And there were 4 units within that group. One is clinical pharmacology, rheumatology, bioengineering, and rehabilitation. He was always looking at a wholesome, multidisciplinary activity within his unit. I was in the bioengineering group, which happened to be one of the 2 pioneering groups in the UK. The other one was in Glasgow, Strathclyde, and the other one in Imperial College. And after that, more groups came out. I spent all of my time at Leeds University doing and supervising research. I became very interested in the knee joint. In fact, it has been more or less my main specialty. So joint mechanics, function of the various components, in particular the menisci. And this led to a lot of research into ligament, where I designed, together with colleagues, a ligament system for reconstruction of ligaments and tendons. The first ligament we designed was with a colleague from Japan, Dr. Kyosuke Fujikawa from Keio University, hence the name Leeds-Keio. That was a good, sound device, but then at the early stages, the technique wasn't fully developed, and while there have been some good results, there have also been some bad results which influenced that continuation of that device until we revisited the synthetic ligaments for ACL reconstruction. And together with 2 colleagues at the company, which is called Xiros at Leeds, a colleague called David Beavers, and myself, and a colleague called Lauren Tidball. She is a very, very skillful textile technology individual. So while we came with the concept and the various dimensions, she executed this by making the structure in textiles. My interest still extended to lots of other areas, such as cartilage repair, such as the role of mechanical factors in the development of osteoarthritis. So ligament is not just my interest, there are others beside.
Fair enough. I mean, it's really great to hear that this has been a thought process and your work that you've been doing over the last 40 years. And I think it's interesting to note that you mentioned to me that you'd seen 𝐨𝐳𝐶𝐞 being used early on when you were a postgraduate by your senior faculty, Dr. Benjamin Joseph.
That was for calcaneus is deformity in the foot.
Yes.
So extra-articularly was doing that to prevent it from going into calcaneus for spastic.
We've come across Dr. Benjamin. Yeah, Benjamin Joseph.
He was there that time. But my exposure was in ACL was on ABC ligament with Angus Strover in Oxford Street. So I trained there. And that's where I saw some disasters with the intra-articular reaction due to, which you tell me is due to the carbon, in that we saw the black synovitism, which scared us. Yes. Which that's the reason which I was always skeptical with putting anything artificial inside the knee other than outside the knee.
Yeah, well, carbon fibers actually could have been used for tattooing. It's just similar, leaving something very similar to what you've seen on the synovium when it fragments into very small particles.
I think that's the nightmare, kind of reaction surgeons have. They're just, oh my gosh, I'm going to have this black synovitis. And I think it's worth talking about that. What's your opinion on, why did that happen, and, what's different now with what you're using?
Well, carbon fiber is very brittle material, and it fragments into very small particles, and this is what causes the stain. ABC ligament had a combination of polyester and carbon fiber, and so when it failed, there have been these fragmented carbon fiber.
Carbon fiber was incorporated for strength?
Yes, that definitely was the intention of Angus Strover, whom I knew very well, and in fact I've contributed to one of his one chapter in his book. Yeah,
I have the book with me.
You have the book here. Yes, okay.
So how have we achieved strength now with the Jewel?
The polyester is a polymer, and it has properties that nearly resembles the natural collagen, and it is stiffer, definitely. You can't actually match it. It requires an immense amount of investment to develop a biomaterial for implanting that is matched to the natural material. So it is stiffer, but it's by no means as stiff as carbon fibers. And I will be demonstrating, hopefully sometime tomorrow, the disabuse of the notion that autologous tissue works like rubber bands, and the synthetic ligaments are stiff as steel cables. I'll just show you that both are not correct.
Fair enough. I think it's worth talking about the fact that there are other companies exploring synthetics now. It's not just you. And another company that I came across recently was marketing a collagen-based, like a biologic kind of brace. I think they basically go along the lines of saying that they're more biological because they're using type 1 collagen from porcine type 1 collagen. So in that sense, they probably aren't achieving much strength, is what I would say, and they're just probably looking at being biologic. What's your opinion on that?
Well, I have a probably controversial comment to make you here, saying this. I don't see any logic in the biologic. I'll explain why. Free grafts, which are pure collagen, they are the natural material. Autologous, it's the same patients. These are dead grafts. The cells have died, and the device which you implant gradually loses strength over 6 months before it begins to recover. It has to be revascularized. It has to be repopulated with cells, and these then have to be active to maintain the structure. Now, this is a very long process. Why? Because dense collagen, very close together, very parallel. For the cells to penetrate, it takes a very long time. It's like you're trying to walk in a forest made of bamboo. You have to keep pushing sideways to enter, and it takes you a very long time to reach somewhere. The same thing happens with these, and in fact there's a paper by Dr. Leutzinger where he observed the penetration of cells into a number of grafts for the rotator cuff, and the penetration is very, very superficial. So what you really need is a device which talking about synthetics, which have got a lot of space to grow, for tissue to grow in. And the tissue ingrowth, there's no magic in it. It's a very natural process, natural body process. Any device you implant gets colonized with tissue. But the amount of tissue is dependent on the amount of space that's available. So if you've got a device that's meant to allow tissue ingrowth, it has to have a lot of space. And in fact, I use the word allow exactly the same way I would say that door over there allows you to get in and out, but it doesn't tell you to do that. So the graft is got space for tissue to grow in. It's a passive structure.
Fair enough. So in the evolution of this ligament, the starting point for you in terms of when it came to being used in a clinical situation was Leeds-Keio, correct? So have you seen a Leeds-Keio being implanted in your time during your training?
No.
You haven't?
No. I saw the ABC.
You only saw the ABC. So the question is, what happened, what changed between the Leeds-Keio and what we're using now?
What has changed is the method of implanting. The Leeds-Keio ligament procedure was elaborate, was precise, and was complex because it comprised removing two bone plugs, one from the femur and one from the tibia. So you did not drill holes. The amount of bone waste is like bone dust. And then there was a smaller tunnel, 6 millimeter tunnel, which was promoting now. And that's a short tunnel. And you place the ligament, which was tubular, and then you put the ligament, the bone plugs either side, and then fix it on the outside with staple and buckle. The reason for this is that the biological fixation, which is where the bone grows from the tunnel through the graft and join the bone plug, that's a time-dependent process. And if you leave it as such, without any external fixation, there will be some slippage. And we've talked about, a loose ligament is a useless ligament. You don't get any tissue ingrowth. But I can also tell you that the difference then lies in the technique. The jewel has got the same structure, the same basic structure, and it is suspended, use a suspensory system at the femoral side. It can be either a fixed continuous loop or an adjustable loop. And on the tibial side, it's fixed with a bone screw. It can be metallic, titanium, or PEEK, but it has to be a soft screw. So the major similarity, which is the all-important one, is the structure, the loose weave structure.
So intuitively, it sounds like when you guys were using the Leeds-Keio ligament, you were thinking about fixation more than now. And is that because things like suspensory fixation were not available at the time?
The suspensory fixation was not available. It started, I think, in the late 80s. And it was actually, they used just a tape and tied it to adjust the size of the loop. But we thought it's better to have a captive loop that is strong. And this is what has been used for the past 25 years. It's been the premier device of that kind. Yes, we've been thinking about the fixation, and it was the appeal of the bone plug integration that appealed, and a lot of people say that was quite elegant to do, but that was what behind us really is the fixation method.
I feel like if I was introducing the Leeds-Keio today, I'd probably go more along the lines of putting a screw into the femur. Why was that not something you considered instead of a bone plug?
At that time, screws were not invented.
I see.
As fixation. It started with Kurosawa very, very much
Kurosawa
later.
Screw. Yeah. That was in the US.
But we'd never have used it, by the way.
There used to be a bollard which Angus was using on the femur. Just swung and we just pin it in there and then and tie it down below with a staple on the tibial side. Now there's something, the weave pattern on the jewel and the weave pattern for the extra-articular tendon repair, like the quartz. It's a much more open weave in the quartz tape as compared to the jewel, which I see is a much more smaller weave Is there some reason why you put that?
The main thing that's important is the looseness of the weave, the size of the.
So why did you make it different for the ACL and the muscle tendon? Is it some
muscle tendon?
Yeah, for the quadriceps tape.
The poly tape has a much the lumens are bigger, but so why is there a difference?
I cannot give an answer. I'm sorry, I don't. It just is how it was designed by the people who designed it, but I cannot give you an explanation for everything.
So how many years into Leeds-Keio did you notice problems?
It was, I think, a paper in...
When did you first hear about it?
Late night. When we heard from a paper from McNichol, and that was early, before we actually started doing the fixation of the ligament on our side. So in fact, he ended up with a loose ligament from the very beginning. That was a time when the technology as well as the technique was not really fully informed. And even the concept of isometry that came later when Fujikawa and his colleagues studied this on cadaveric joints. So that's what happens with a lot of devices when they are not fully developed and the technique for using them is not fully understood.
And correct me if I'm wrong, this is open surgery. It's not arthroscopic surgery, right?
It was open surgery.
Yeah. So how many open surgeries did you see when you were training? All your ACLs were probably open back then.
When I was training in India, it was all repairs. Then I landed up in UK in '89, and that's when I started seeing reconstruction with bone patellar tendon grafts and the ABC.
It's still open?
No, it started getting partial open on the femoral side. We used to open and fix it onto the femoral side, outside on the lateral cortex. But inside, yes, there's some scope, which is arthroscope assisted, not as fully arthroscopic now.
Yes.
So we've done a lot of talk on ACL, but at some point your interest kind of went towards solving other issues and tissue, muscular tendinous issues in the body. What made you bring in polytapes and those kind of uses?
The polytapes were actually a very early development, I think in the late 80s, and it was actually initiated by one of the sales and marketing people from Hamedica who were then distributing that. I said, why don't you produce a number of tapes for different applications? And so we did. I mean, we don't take the credit for everything we've done. A lot of people have contributed by coming with good ideas, with good suggestions, and so that's how it happened. But of course, it was quite important to see how the different tapes were used for different applications, and a majority of these came from Japan. So our colleague, Dr. Fujikawa, was the one who developed the extensor mechanism, and his paper is the earliest, where he did 26 patients. And that was a very, very rewarding thing, because extensor mechanism rupture is disastrous and it's crippling. You just lose mobility altogether. And the other is the Achilles tendon reconstruction with a much narrower tape. And those two actually are possibly the most crippling and most debilitating of injuries, and yet these devices are most effective in those two particular, as you have actually yourself observed.
I'd like to ask, when did you first come across the polytape? Because you started using them quite a long time ago.
So in 2012 is when I started using it. But what made me think when I was starting to search for something to repair a quartz rupture in a post-TKI patient was every time I use semi-T for patellar tendon, even in the native patellar tendon, they always stretch out a little bit. They always had a bit more laxity, something. All the biological tissues stretch out a bit. So it is never as tight as what they always are a lag bit longer.
Wonderful.
So, I mean, I think it started off being called the neo ligament, which I think is a fantastic name. It's my favorite name for it, but I mean, obviously you've changed the name. So you very quickly used it for quads, but did you use it for any Achilles yet?
No, I'm not using Achilles.
Not yet. Just going back to differences between different braces, the other brace that I've constantly seen used, especially during my training in Australia, was the 𝐴𝐧. What's different about the 𝐴𝐧 and the Jewel?
First, the strengths. The LARS have used something like 5,400 or 4,500, nearly twice the strength of the ACL. Thought it would work well, but that's excessive, and it's also a good reason why tissue and growth would be even more inhibited. You really need some stretchiness in the device you implant. The stiffer it is, there's a threshold of strain below which cells don't respond. We've done some in vitro studies, and we've got 2 papers on this. You can actually see it. That's one thing. The other is the structure itself and the method of fixation. It is, you drill a large hole and use a large screw. It's, forgive me, it's a bit brutal somehow. The other thing is the structure of the intra-articular section. That's a very packed length with thousands of monofilaments, very close, and that actually doesn't give space for tissue to grow. And it's just like the cells trying to go, like humans trying to walk into a forest of bamboo. So it's that's a big difference. And then the outcomes, I think.
Yeah, I think you mentioned in one of your presentations that I had the privilege of watching, but basically if there is a rupture, the monofilaments just start coming out like you have in a dandelion, and they just start going around the entire knee and irritating the synovium.
Yeah, and that's the explanation of why synovitis has been observed more with the LARS, and so far in more than 7,000, we've got 2 reports, and one of them was a poster. And the reason is that the jewel being loosely woven, it allows tissue ingrowth, so even rupture, when it occurs, the device is still enclosed or colonized with tissue. And that prevents or ameliorates or slows down the generation of particles that cause the synovial reaction that you're talking about, synovitis.
So another point on that, when as surgeons, when we implant things, we're always worried about infection, especially being joint replacement surgeons. Even in a patient without any infection, they have an implanted knee, they get an infection somewhere else. We always have the worry that it's going to find itself through the bloodstream to the implant. Do you think that applies to the jewel or these sort of implants that are?
We haven't had any reports about infection, and people are asked for, and if any of the salespeople hear about any problem, they are by law instructed to report this immediately to our QA group, and this has to be investigated. So far, we haven't had a single infection report. Some surgeons say that they have observed some, in some cases, not necessarily ours, when they observe certain infection, they treat it and it goes away, so they don't report very much about it. So that's why, even if it happened, we have not actually heard in any genuine manner.
I'm going to ask a question quickly. What do you think the benefits of a synthetic ligament are in your practice and what you see going forward? What are the big take-home things?
For the intra-articular.
For the intra-articular, if you were to use a Jewel ACL, what are the things about it that really draw you to it? What are the big hitters that,
I think first thing should be the immediate full activity level, because it's not biological, so it's going to hold it straight, so you can probably start rehab much quicker.
So strong on day one.
Yeah, because I know that anytime any surgery you do, the muscles go immediately, and we're always slower with biologics. So probably that's one of the biggest thing to get me back into to rehab or back in action much quicker. So that's a big, if it works, that's a big thing for me. Other than that, of course, I was talking to him earlier, and he said he gets type 1 collagen inside, which is more like normal. If that works, yes. I was worried about foreign body reaction or giant cells. You said there's not much about that. He said there is giant cells, but it's more collagen, type 1 collagen, which goes.
Well, we have only observation of tissue in growth is necessarily always about small numbers, because you have to have a second look. And if you have to have a second look, you've got an ethical reason, whether it's either damage to the meniscus or rupture. Otherwise, you can't. But if you've got too many cases that you have to go and have a second look because the ligament has ruptured, you've got a lousy ligament. It's got to be withdrawn completely from the market. So
in the ACL, you have large fiber diameter collagen fibers and small fiber when you do the electron microscopy section. So I've seen some reports, and there's a picture where they have two different fiber diameters inside, and which we try to use with a hamstring. It never gets back to the same. So even after...
Are you talking about the actual structure of the ligament or the actual structure of the
section,
tissue, the engrossed tissue?
No, the ligament.
The arrangement of the collagen in the ACL, you have small and then slightly bigger.
Oh, yeah. Well, no, I'm not sure of the last time I saw the paper and the pictures on it, whether there were two different fibrils, actually, nanofibrils. No, I was wondering if you were asking about the structure of the ligament. The monofilaments are the same throughout. It's about 24 microns.
Because why I asked you that is because I said the elasticity. Told you this thing about earlier. But when I examine a patient, when the patient is resting, and a normal patient, if he goes for a run and come back, I feel the ACL is slightly lax. And after an hour again, when I examine the patient, it feels gone back to what was originally normal. So is that to do with the fiber element? So that's why I asked you, is your tissue elastic, or is it plastic deformation that you have?
You're talking about the device itself, yeah. The device is a polymer that is known as viscoelastic, which has an elastic element and a bit of creep. After some time, after the rest, the creep returns back and you end up with the same. Otherwise, if it continues to creep, after some time, you'll have a continuously lax joint.
So that means you're saying it's more like the normal ACL?
I haven't compared.
But it's closer, because with a biological graft, what I'm going to put is I'm just going to get scar tissue back. I don't know whether I have the same elasticity. Whenever I check a biological ACL, I get a good endpoint when it's working well. Yeah. But I'm not sure it's the same. We all talk about stiffness. I think what is important is these tissues are elastic. Right? All biological tissue is elastic. If it's too stiff, it's going to break. So some giveaway has to be there, isn't it?
So you're saying you didn't give me any other reasons except for the fact that you think that this has strength, and now with this discussion we're kind of pointing in the line that it probably has strength resembling the native ACL, while a tendon, an autograft, has tendon properties of a muscle, and it doesn't. And it's quite interesting that you said that a patient after exertion might be a bit laxer than I haven't actually noticed that. It's very interesting. Maybe it's something we should be studying. And that could be another thing that we compare with our jewels versus this. But if we were bringing back that level of viscoelasticity using a synthetic, that would be another really important thing. But for me, just going back to the advantages, I think donor site morbidity, just the second incision, which is probably the smallest thing, but I am so careful with my hamstrings and my quads. When you and I have both moved away from using hamstring grafts, and we've seen better recovery. We've seen that a hamstring tendon is an agonist with the ACL, so you shouldn't touch it. And so we moved to quadriceps tendon, or we started using peroneus tendon, but there's still a sacrifice happening. What if you had no sacrifice? And I think for me that comes to number one, because there's pain and there is a weaker muscle. The quads sometimes go into shock, and we've got those papers about a muscular inhibition after. So I think that's the main thing. So then it points me to say, why have we even talked about a hybrid jewel? Because I think it's quite important to understand that you're just taking away one of the major advantages when you do a hybrid jewel. What are your thoughts on that?
Phrase now is preserve your patient's biological capital, biological stock, both the muscle as well as the bone. And that's the reason for use of the graft as standalone. But there's something else. I mean, apart from the saving the biological capital, the use of even something as small as the gracilis as you say, it will take time to harvest, it'll take some time, it's a deficiency, etc. But besides, I'm not quite sure how useful that additional graft is contributing, because the problem is that it has to be revascularized, repopulated with cells, which is precisely the problem I've been mentioning. Whereas if the ligament is used by itself, it will be colonized by tissue in its entirety. So that piece of autologous tissue put in is in the way of good tissue that is actually going to be subjected to the mechanical stimulus.
Why can't we just simply put mesenchymal stem cells from the patient onto the ligament before we put it in, or after putting it right onto the intraarticular part, rather than waiting for things to flow in? Why can't I just put that with some glue in there? We use fibrin glue or thrombin.
Some people are doing this. Some people use PRP and rotator cuff repair with our patches. Professor Ofer Levy, you may have come across him in Reading, does use PRP, and he is very happy with.
I'm talking about using cells, mesenchymal stem cells, MSCs. So you said when you drill the bone, you get some cells coming down. So
this
PRP
actually,
doesn't have any cells.
It seems like it's a natural process. It's how the ligament is colonized. It's just the mesenchymal stem cells that come from the bone marrow through the tunnels, and also the synoviocytes. These are all stem cells, and synoviocytes are pluripotent. As you know, they can differentiate, and they can end up as cartilage or ligament or tendon or bone.
They have the best. The best. Sakia's paper says they have the most pluripotency. But this is a discussion we had maybe a couple of weeks ago when we met in Bangalore. And what I asked you was, what about biological augmentation? And then we went on to talk about the coating of the ligament, and you mentioned it's hydrophilic.
It is actually the process is a plasma treatment that doesn't actually include any blood plasma. It is the device is in a chamber, and it is subjected to an electric discharge, and that actually more or less is like roughening a surface which you want paint to stick to, but it is just on the nano scale, and it's lots of sites are released for proteins to adhere to it, and then cells adhere to the proteins. That's for the Jewel ACL, because it's treated with this plasma treatment.
So it becomes like negatively charged or positively charged?
Whichever way that attracts proteins. I mean, I'm not a biochemist, but this is my understanding of the process.
And when we handle it, are we discharging it or anything like that? No.
No. The thing is, this is the same process that the body does for something like the Leeds-Keio ligament or any of the polytapes. They are not treated, but the body enzymes do some etching to the surfaces and cause exactly the same effect of the plasma, except it takes a bit longer. So all of our tissue ingrowth data that we have been sharing with you have all been on untreated devices. And it's interesting, there's a paper, 39-page paper, that demonstrates that the devices are populated with cells, whether they are treated or not treated. It's probably the speed by which the adherence of cells occur. So the intention is to accelerate that tissue adhesion, the cell adhesion to the Jewel ACL.
So the intraosseous part of the ligament and the intra-articular part of the ligament, once it heals, is it any different, the tissue? Inside the bone, does bone grow into it?
This is something I don't know about, because we haven't had an opportunity to see in a second look what is the space between the device and the bone tunnel, what actually occupies it.
So if you do CT scans, you could sometimes make out if bone grows into it or not. I don't know.
Bone growth, most likely because of motion, the micro movement may be a bit larger than would allow bone ingrowth. It might very well be good tissue, and its advantage is it protects the ligament from abrasion against bone.
So do you get Sharpie's fibers there?
I have some good slides for you, but these were made on a canine model where something you might find quite interesting. In that, it's about 56 mongrel dogs have been operated on in Japan and in a number of groups. In one of the groups, they tested the possibility of gouging the tibial stump altogether. So you can see bleeding there. And within weeks, you can see that it's generated, and then the histology shows sharp piece fibers. It's amazing. And this when people are always saying, I want to keep the tibial stump, and they insist on doing that. It will be probably a while before I can show, guys, you don't need to do that. You remove it to release, give a space for the new tissue to come in. I had a discussion some time ago with Jean-Philippe Lebereau at the time when before he started the LARS. He was using the Dacron, and he had a large piece of the ITB and wrapped it around and sutured it to use it. And I just, why are you doing this? It's in the way of tissue growing. And he agreed with me at the time, but that's a very long time ago, and we were actually doing very well with the Leeds-Keio ligament.
I mean, another question just based on cell proliferation and the kind of cells that populate, because we said it might be type 1.
The type 1 actually is a very long process. You get something like almost like scar tissue, and then under the influence of mechanical stress, it becomes a line. When exactly it turned into type 1 collagen, we don't know, but we know that at 6 years and 4 months, that the biopsy showed type 1 collagen. How much before the 6 years it happened, I don't know. We have no way of finding.
That is throughout the ligament or certain areas of the ligament? This type 1 collagen you found all around?
It's a biopsy, and the biopsy is, and especially to observe. Well, the type 1 collagen is actually characterized or discovered by using monoclonal antibodies, and they get a stain for type 1 collagen. But the biopsy has been subjected to transmission electron microscopy, which is a very high magnification. So necessarily, the specimen you take is a tiny thing, like a cube.
What about retrieval studies from any of your failures? Have you taken any tissues and looked at it?
What about the canine ones, the retrievals you had?
The canine, no, but the canine was done actually a very, very long time ago, before a lot of these things, including the typing of collagen.
But nothing in human retrieval studies.
In the 80s was not available. The monoclonal.
So still no data with human retrieval studies on that. Fair enough. So the question I had was, there are some giant cells and fiber, and that for us means fibrous tissue, scar tissue. It's a foreign body reaction. Those are the kind of things we are taught to kind of see when we say a giant cell. But you're saying it's a process where the scar tissue has to come in, there's a foreign body reaction, and that slowly those cells start to have, they're in the evolution of slowly becoming well-organized collagen.
Yeah.
So I'm correct in that. The second thing I want to go into is the technique. So we're all in agreement that a suspensory fixation on the femur and a interference screw on the tibia, and lucky enough, that's how a lot of us do our ACLs these days.
And that was the rationale behind the design of the Jewel, is that it's the technique, that prevailing technique could very easily be applied with the Jewel.
So just to talk about the kind of cells that come and populate the Jewel ACL, some of the studies, or some of the literature that we looked through, we did anticipate that it was a foreign body reaction with fibrous tissue, or a giant cell reaction, as it were. When do you think, or what kind of cells do you think actually come and populate, and at what time point?
Well, the process of tissue ingrowth starts very early, almost immediately post-implantation, and that's by the more bone marrow mesenchymal stem cells populate the device. Also other stem cells like the synoviucytes. Incidentally, the fat pad cells are also equally pluripotent like the synovial. So all of these land on the surface of the monofilaments, and when they're subjected, when the ligaments subjected to the mechanical stimulus as a patient walks, it's subjected to cyclic loading. That stimulates the cells to change their phenotype, become spindle shape like, and begin and continue to secrete extracellular matrix, which is loose tissue to begin with, but then it becomes bulkier and becomes more aligned along the line of the tensile loads, and with time the tissue can become type 1 collagen. This has been observed on one case by the Dr. Zafanieni and colleagues a long time ago. One patient who ruptured his ligament at 6 years and 4 months, and they discovered type 1 collagen in the biopsy that they have taken. So when exactly the type 1 collagen was present must have been a bit before the 6 year and 4 months, but how much earlier, there's no way of finding out.
So you're saying there is no phagocytic foreign body reaction?
The entire process is a body reaction. It's a natural body process where the colonization is a natural body process, and it would look like fibrous tissue to begin with, but then it changes, it remodels, and that's the entire process, the contribution of the mechanical stimulus to the maturation of the tissue. It's a process that takes time.
So another big advantage for me using the Jewel ACL would be that we use much smaller tunnels.
Yes, actually you're replacing the anterior medial bundle, and the footprint is about 6 millimeters. So you are actually in an area which allows you isometric placement, because the anterior medial bundle doesn't actually change its length during joint movement. And
so some surgeons, and correct me if I'm wrong, would assume that the anteromedial bundle plays a more important role in anterior translation, while the posterolateral bundle plays more of a role in the rotation. So if we're not going to reconstruct that bundle, what do you think the biomechanical implications of that are going to be for our patient? Do we need to do an LET? Do we need to just pray that they don't have anterolateral rotatory instability?
Sure, I can say a few things about this. Reason for reconstructing just the anterior medial bundle is a pragmatic reason. To reconstruct both is a very laborious and a very exacting and a very difficult and hazardous process. So that's one reason. As for its contribution to controlling rotation, I don't believe that this is significant. The ACL in its entirety does contribute a certain or a limited amount of control on the rotation of the, but the majority is on the extra-articular structure. And you do an LAT if you have very loose joint and the reconstruction of the ACL is not adequate to reduce the rotational movement to normal. So that is one important thing. And you have to control the rotation by an LAT. It's like steering a steering wheel of a car. The ACL is in the hub, if you like. You don't steer the car by holding the hub of the steering wheel. You hold it on the outside. And so trying to have a thicker ligament to control the rotation is no more than increasing the diameter of the hub. That doesn't actually help. All your control of the steering is on the rim of the steering wheel.
You still got to, think about anatomy. When I spent time with Dr. Shino in Japan, I worked with him for a year, and he always said, George, follow the anatomy, follow the anatomy, follow the anatomy. And when you follow the anatomy, you still have a bundle there. You still have a posterolateral bundle. You still have a ribbon-shaped ACL. We were talking about 𝐵𝐼𝐬𝐜 earlier. So to suggest that we need to control the rotation extra-articularly and only rely on this intra-articularly, I would think about the fact that, do we need to think about that factor, and do we need to look at a partial injury here, or do we need to look, if we have a complete injury with a lot of rotatory instability, is this something that we need to be careful with?
It seems like in 30% of the cases of ACL reconstruction, you need an LAT, and that's actually indicative that the extra-articular structures, which are normally in control that rotation, have become very loose. So it depends very much on the state of the joint. The chronicity is quite important.
Chronicity is important. So we were talking to a couple of surgeons in Bangalore when we were at the conference, and it was highlighted that in India we see a lot of patients chronically. We don't get them in an acute phase, and by then they may have stretched out their anterolateral structures. They may be a bit laxer. They may be pivoting more. Do you agree with this?
I think we are seeing more people early here. I'm seeing people within weeks. I'm operating next day sometimes, so we don't get much chronic.
I mean, that is our practice. I agree with you. I also felt like that was not something that we typically could relate to. But while I was operating in other parts of the country, I did notice that patients were coming at 6 months and 1 year, and usually a little bit later.
Yeah.
And in that situation, would you advise maybe this is not the solution there, and we need to think a bit more carefully?
Time of the intervention is absolutely important. So if somebody comes to you with an ACL and healthy, fit athlete, reconstructing it as soon as possible is likely to give you a very good result. If you have the same patient not attended to for a number of years, well, there's a paper by Irvine and Glasgow that any unattended ACL deficient knee ends up with about in 86% of the cases with 1 or 2 lesions on the menisci. You remove the menisci, as day follows night, you get arthritis in the joint. The muscles atrophy. The joint becomes looser and looser. If you then sort of reconstruct the ACL, what have you done? You just link the bones together and probably improved a little bit of the laxity, reduced the laxity. But then that ACL reconstruction is not going to be a substitute for a meniscus that has been missing. It's not going to reverse the degenerative changes. What I say to the surgeon when I've spoken with many of them, it's up to you. It's your decision when to operate. This is provided that the patient comes as soon as possible, and it's not the patient who's actually delaying in coming. But if you do so, by all means, it's your decision, but please ameliorate your expectations. Don't expect the results with an early patient when you've done a good reconstruction are going to be reproduced in a patient who's come to you with a chronic case and a loose joint. It just is unfair. You can always compare the delta, how much improvement has happened to a very bad joint. But
have you used the new ligament for LET?
For what, sorry?
For the LET.
For the tenodesis.
Tenodesis. Have you used
Føljikawa used it in the past, but in fact he was a bit over the top because he used the long ligament and passed it from the tibia to the femur and then
brought it back down.
Yeah, and that was a bit too, it was over the top. You don't need a very large construct here because it's a thickened capsule. There isn't a ligament there. This is the ALL, but the ALL is so flimsy as well, so you don't need to have a massive construct on the lateral
but
side.
you have not used it. You don't have a separate device for that because if you're going to do it,
you can use a thin, narrow polytape like a 10 millimeter polytape, and that would be more than adequate.
More like an ALL reconstruction using a polytape. Yeah. Possibly something we could think about. So another advantage that I see is probably surgical time. And I know this is something that's probably going to make your fellow or your graft preparation person have a little bit more wiggle room. But I think you will save time in surgery. You will reduce your anesthesia time. Somebody I overheard saying, you can use this if you drop the graft on the floor. And I said, how many grafts have you dropped on the floor? Because I haven't had one of those yet. You've had a graft on the floor? I guess it's something that happens over time when you least expect it.
Or a graft that actually is weaker, not good property, mechanical properties. It looks flimsy. Also, if it's cut too short,
Yeah.
all of these things do happen. Actually, they have been reported. I'm not making it up.
Yeah, of course. We add antibiotics to our ACL grafts. Is there anything like that we need to consider? Has it been thought of here?
I know that many surgeons use antibiotics as a prophylaxis. And so they actually redo it a day or so before and do it a bit after. But
Not on the ligament or inside
not on the ligament, no.
Another just a fun question that I had for you was, anyone close to home, family or friends, colleagues that have had a Jewel ACL that you closely get to see every day and ask how they're doing?
No, I know our distributor in South Africa had one, and a brother of a friend of mine had one, which lasted him 6 years. It was a revision case, and it was done 6 years ago, and he had a semitendinosus repair. So we don't know how the revision was done. Did they use the same tunnel? If that was misplaced, then it lasted in long-term rupture. He was a gardener. He returned for 6 years to do his job, and he was a football coach, and he played football with his son, which meant quite a lot to him at the time, because his kid was a young little lad and preferred to play football with his dad rather than with another kid's dad. So it did make an impact on the quality of life, but all the same, a misplaced ligament can always give you trouble.
So as a surgeon, I know anything I do can fail due to my skills, the patient, or sometimes we don't know why it failed. You told me that it doesn't cause synovitis for clear. So there's no reaction like some of the other old artificial ligaments we used. No synovitis. You don't have fibrosis other than fibrosis in the ligament. You don't get adhesions between the ligament and the PCL. You don't get adhesions between the ACL and the fat pad. You don't have anything like that. You said that. Ruptures can occur. Anything can break.
And ruptures are, I believe, the most important type of failure. I've done a paper talking about analysis of failure. And I didn't mince words. Every type of failure, including, first of all, the rupture, laxity, instability, synovitis, inability to go to sport, lack of tissue ingrowth. I've listed these and just wanted to analyze which is associated with what and which is a result of the other. And it seems to me like rupture is the culprit, the biggest culprit, because ruptures increases the laxity. Laxity can end up with instability. It can end up with synovitis. It can bring pain, and it can also limit the ability to play sport. So while you can say one leads to the other, some are associated with each other, but the most important, the most severe is the actual rupture. That is what results in all other kinds of failure. And so it plays a lot of...
How do you remove the ruptured ligament? Do we just shave it off or you pull it out? Or
Dr. Kusovsky, who's done a few of these, advises against using a shaver, because if you use a shaver to remove it, or the shaver, you'll be using 30 shavers because of the... it'll be clogged very quickly with the fibers within the ligament. And he proposes using some kind of a semicircular gouge to release the ligament from the tunnel of the tibia. This, of course, after removing the bone. But you also have an experience by using a hollow reamer to remove it, and that's effective as well. The important thing is to avoid enlarging the hole, so you can replace it to a revision, but all the same using a slightly larger screw. That's far better than going with a drill bit and removing quite a lot of stuff.
So stay away from the shavers.
𝐁𝐚𝐡𝐴. That's definitely the recommendation of Dr. 𝐭𝐡𝐢𝐬, and I'm sure this is based on experience. He probably tried it once and decided it was the last time as well.
So, you've used it a lot for extra-articular. What has your experience been? Have you seen any failures there? Any issues there? Anything you would say you would look at to improve it? Any comments?
Extra-articular is fantastic. I've not seen a failure. I've not seen an extensor lag. In fact, I saw a patient today who was 8 weeks. I think you did an MR on that. And she was already full SLR at 8 weeks, which no way with any biological repair will happen. Of course, she bent only to 90 because she somehow was restricted.
And this was a patellar fracture, proximal patellar fracture, post-knee replacement with a quad rupture. And
Did you put that on your...
Yeah, we presented that. You've seen that slide.
Yeah.
So she was here in the clinic today, and she's...
Yeah. It is one of the most successful and most gratifying for you, the surgeon, and for the patient on the receiving end, because you save their lives. You restore the function of a joint.
Because I was at the meeting when we were in Amsterdam, and over there someone said, "This is my backup plan." I said, "This is my only plan. I don't have any other plan. This is the first plan." And I think it's such an amazing implant, and I look forward to using it for MPFL reconstructions as well. I haven't yet done one, but I think it would be a great there as well, because you get a good graft, you get length. Sometimes we have a short graft and we can't, and using a semi-T for a MPFL, I think is using too much graft. I think we waste a lot of graft.
This what you see here is a very, very simple procedure and very effective and proven to be successful. 𝐭𝐡𝐢𝐬, who came up with this technique, has done scores, and he's very satisfied. He published a paper about it as well.
The fixation for the post-humeral corner is with sewell lock or some screws only?
Screws. Because the tape's quite thick. It not goes through any of those kind of devices, swivel locks and Tino locks, those sort of things.
So you're using 6 mm tunnels, and you'll use 8 mm screws, or
2 sizes up. So for the Jewel, it's a 5 mm tunnel or a 6 mm tunnel, I think, and you can use a 7 mm peak screw. But as long as it's a soft screw.
Somebody in one of the countries in Europe has ignored the importance of using a soft screw, and he cut the ligament on the table, and he had to replace the device all over again. And I think he probably never did it again. Soft screw is so important.
So where have you seen the highest amount utilization of ACL? So synthetic ACL, where have you seen the highest utilization, the highest interest? Because you've got 40 years worth of utilization. So where have you seen the biggest amount of interest for this?
Well, the biggest amount of use has been actually in Poland and in South Africa, and then in Italy. There is some use of it in Spain. Our colleague Mikel Sanchez, who did in the past about 1,000 Leeds-Keio ligaments. So these are the major.
But so these are not typically countries that are high in sports. Some of them, Spain and Italy, are doing a lot of sporting. But the countries like, the UK and America, where there's so much sports and so much economic pressure on athletes to get back to sports and not miss seasons, it's amazing that it hasn't really picked up there yet.
Yeah, in America, we're hoping that our application would be accepted, and it's going to be approved in the not distant future for augmentation of ACL and PCL. And then that would be quite useful, because it's a much better alternative in terms of strength than other devices that are in current use.
And so what brought your interest to India? Because we are just beginning to win gold medals and get onto the sports scene. We haven't typically had very good football teams. We're just beginning. We've got the Indian Football League slowly building up. Kerala has its own Super League slowly coming into place. So we are anticipating to see high demand, more injuries, and then they want to get back to sports faster. But I don't know if you had that information when you decided to start, bringing this technology here.
We didn't know what to expect, and it has been an amazing experience. And the reason for me coming here to spend 3 weeks is to see as many surgeons, possible users, to exchange information and deliver a uniform message to everybody, because very, very careful about. We want things to be done, getting the best data to avoid the previous experience.
Yeah, I think the time I've spent with you, the few times I've met you, I think the most important thing that you've kind of repeatedly told me is technique is everything. And I think we've agreed that data collection is also everything. And this time around, if a ligament like this needs to have a success, we need to be systematic. We need to all make sure we're doing it the same way uniformly and collecting the data on it in order to actually find something. And this would be a huge leap forward for sports and recovery.
And this is what we aim to do. And this, one of the purposes of my coming here is to make sure that this, I think it's a 4-center trial, is initiated and commenced.
So there's a trial going on right now in India.
Yeah. Well, people have started sooner, but it needs to be officiated with the protocol and everything. But the people in those centers, some of them have already started.
Is this being done in China and Japan and Korea and places like that?
No, we have no activities in China. It's very, very difficult to register anything in China. It took us 7 years and didn't happen.
What about in Korea and Japan?
No. Japan is
Even for Jewel?
Japan,
for ACL, they're using?
No Jewel, no. But Japan is a very important participant in our activities. We started. No, I don't know. Maybe some of the Japanese distributor might have activities in Korea, but we don't know exactly what's happening. It's a good place to go, South Korea, and we're hoping sometime to do this. Malaysia, we have an activity there as well.
I mean, I've spoken to my previous fellowship directors, and I've talked to them about this, and some of them have looked at me and said, "Why? We've been here before. We've seen the results of this before," and then some of them have said, "Why fix something that's not broken?" But I think my answers to both of those things are, of course, we've been here before, but we've learned a lot over the last 40 years and what's happened before. So we're trying to get better. And I think
what is that something that's not broken? Why fix it? What actually was he referring to? That
what we've got right now is good. But just on the first one, I think spending time with you, I've realized you've spent a lot of time fixing it. You've spent a lot of time trying to improve what you learned from your failures. You've got data, you've collected research, you've worked with surgeons, and I think you're passionate about trying to get it right. And otherwise you wouldn't have, put so much time and effort into that. And we do really appreciate that you've come down and you're spending so much time here in India, spending time with surgeons. And the second, why fix something that doesn't need fixing, I think a lot of people, it's accepted. Doing an ACL reconstruction with a hamstring is accepted. When you started doing them with a peroneus tendon, there was pushback. And on the arthroscopy groups across the country, we still see a lot of people saying, why would you use a peroneus graft? Why would you sacrifice the ankle joint? Why would you not take a hamstring tendon? But, moving away from the norm is always, like you said, courage. You need to be a bit courageous and you need to have but if you've got good reasons for it, I think it's okay to do that. And
I think once people experience success of it, and in fact once they start to use it and feel they have actually achieved at the end of the surgery full flexion, full extension, and a comparable laxity with the other side, then you can be very confident that you've placed the ligament correctly and you can expect good data. But then the joy of not having to harvest, the joy of a quick procedure, that will continue to attract the surgeon to use it, so long as the first experience, second experience are as that positive.
I mean, even the patient. There's so many benefits for the patient in this. And the only thing I tell my patients when I counsel them about a Jewel ACL is, we're still studying how it behaves. That's probably the only disadvantage and downside. And if it tears, you might have a synovitis, but we're realizing that's not the same case with this ligament now. So I think lots and lots of positives, and I think the work you've done is incredible. And thanks so much for spending time with us.
I just want to add one thing. When you asked me when would I would think, definitely a multi-ligament.
Yeah.
That's where I think when you need 4 and 5 ligaments, especially in obese people, where I need more strength, then my biological stuff is going to stretch out. I've noticed that when I do PCLs or ACLs in very obese people, they seem to be more lax. So that's something.
I've done some study about the forces that act on the ligament, I don't think it has a lot to do with weight. In fact, a lot of weight might actually reduce the amount of load on the joint. I'll explain it sometime if you want to. It's a mathematical thing, and geometry of the joint is quite important.
That's really interesting.
I have been totally surprised. We've published a paper or two about this aspect. The geometry of the joint has a lot to do with how the ACL is loaded.
Interesting. In a multi-ligament, then would you use an autograft for the intra-articular and favor extra-articular polytapes, or would you go the other way around and use intra-articular synthetics and extra-articular biologics? Because it would be a very expensive operation to use 4 or 5.
I would use because I've been using extra-articular new ligaments. So I would use this probably for the extra-articular and use autograph for the intra-articular stuff.
What's your thoughts on hybrid jewel, where you use a tendon with the jewel? We spoke about that earlier, saying that we probably wouldn't want to do that.
I know it was pushed in, at least I remember seeing in, I think it must be the same Polish gentleman. He talked about that. He said that when the graft is thin, he puts the gracilis into the jewel and then puts that. I've seen that video a long time back and the lecture he gave, but I'm still not.
I think, just to clarify, 𝐭𝐡𝐲 started with using a hybrid, and his testimonial is after some time, when he got confidence, started to use the Jewel standalone. I think he used the Jewel standalone a good few years, like 5 to 7 years. So people have gone through this journey, and he did a video showing how to use the Jewel in a hybrid modality. But the last video that we have, which is already now on YouTube, is how to use the Jewel as a standalone device. And where the emphasis is very much about technique, including isometry and keeping the ligament under tension when you do the final fixation.
So thanks, Dr. Bahaa, for spending time with us. It's been really informative. I know you had a lot of places to be in India. You're traveling every day, and it was really good to spend time together. We learned a lot from you, and we hope we can be in touch and share our experience and ask you more questions as they arise with our use of the synthetics. We've been using them since 2012, and we've been very happy with them. So we hope now that you've brought another product to the Indian market that we can continue to have those good results. Thank you very much.
Well, thanks. It's been a very special pleasure. Thanks for having me.
And hope you have a good time in India.
I'm having a whale of a time. It's a lovely place. Thank you.